I'm delighted to introduce our next speaker, Dr. Cynthia Boyd. Dr. Boyd Dr. Boyd is the Mason F. Lord Professor of Medicine at Johns Hopkins University School of Medicine, where she directs the Division of Geriatric Medicine and Gerontology. She also holds joint appointments in health policy and management and in epidemiology at the Bloomberg School of Public Health. Dr. Boyd's career has been dedicated to improving care for older adults living with multiple chronic conditions. She's a former Robert Wood Johnson Faculty Scholar and Beeson Scholar, and her research, which is funded by NIH, AHRQ, PCORI, and others, has changed the way that we think about multimorbidity. She's a devoted mentor, helping launch the careers of many junior colleagues. Dr. Boyd earned her MD at Duke, her MPH at UNC Chapel Hill, and completed her residency and fellowship at Johns Hopkins. Her honors include the AGS Outstanding Scientific Achievement Award, election to the American Society for Clinical Investigation, and fellowship in both the ACP and AGS. Dr. Boyd, thank you so much for coming to speak with us this morning.
Thank you for having me. It's a pleasure to be here. I'm going to be talking about older adults with multiple chronic conditions and be thinking about de-prescribing in the context of taking care of this population. I serve as an author for Up to Date. So our objectives today are to describe the challenges and complexity of multiple conditions. I think if you're here on this course, you probably bring a lot of lived experience with this, but I do think sometimes it's helpful to have framing around how we think about caring for multiple chronic conditions in clinical practice. I do mostly primary care and consultative geriatric care myself in Baltimore alongside my research. We also will talk about preliminary strategies for clinical decision-making and de-prescribing in the setting of multiple chronic conditions. So what is multiple chronic conditions? Sometimes this is referred to as multimorbidity. This seems to vary a little bit across countries. But one way to think about it is the prevalence of having 3 or more chronic conditions. So over half of older adults have 3 or more chronic conditions. The number of people who have 3 or more depends in large part on how many conditions you're counting. So sometimes in the literature, you will see sort of varied data for how common multiple chronic conditions is. But even when you're only choosing a relatively short list of like 10 conditions, a large number of older adults have 3 or more, or sometimes it's referred to as 2 or more chronic conditions. This population is not surprisingly at increased risk of death, institutionalization, increased utilization of healthcare resources, decreased quality of life, and higher rates of adverse effects of treatment or our interventions. But in the recent decades, almost all of our existing guidelines have a single disease focus. Over the past 10 years, there have been an increasing number of studies and guidelines and documents that have focused on trying to think about how do we expand from that single disease focus. But certainly from my perspective in clinical practice, there's still an awful lot that drives us towards thinking about diseases one disease at a time, and it all just being kind of added on top of each other. Quality metrics, sometimes even the way we do our notes and the EHR set up kind of help contribute to that driving towards that perspective. But the best management to decision-making and clinical management of older adults with multiple chronic conditions remains unclear. So a thing that goes along with multiple chronic conditions is taking a lot of chronic medications. 2/3 of older Americans take 5 or more medications, and there's good literature to suggest that many of the medicines that this population is taking are either inappropriate or unnecessary. 20 to 30% of older adults take 1 or more medication that's on a list of drugs to avoid in the elderly. You may have heard of the Beers criteria or STOP. 40 to 50% of older adults who are taking proton pump inhibitors do not have a discernible indication. Some data from the veteran population suggests that more than half of older veterans are using 1 or more medicine that's not effective, not indicated, or is duplicative. And 1/3 of older adults receive a guideline recommended drug to help one condition that may actually worsen another condition that they have. And certainly these problems exist across the age span, but aging is where it's most common and harmful. So a key message I want you to take home today is that the appropriate use of medications involves both prescribing medicines which are appropriate and will benefit the person, and will de-prescribing medicines where the risks outweigh the benefits. And this concept is sometimes called medication stewardship. So here you can see this concept of this balance of benefits and harms, where we're thinking about why, how effective it is, how long they should be taking it, the person's prognosis or life expectancy, balanced against the potential for harm, whether that's adverse drug reactions or interactions, which could be between drugs, or it could be between a drug and a disease, the pill or administration burden people have, or cost. But I think a key piece is that there is not one answer for most of these complex patients when we're thinking about what are the right medicines. That the concept of benefit depends on people, how people value outcomes, what their goals are, what their values are. And so it is a place where we need to recognize that there's not a single answer for every patient with the same set of conditions. So medication stewardship should be based on the best available evidence of benefit and how that relates to harm. It should be goal aligned rather than guideline driven. It should occur in context of other therapies, and that it is something that we have to monitor and reevaluate over time. We need to involve patients and caregivers in the decisions. And a key piece of it is that it often involves de-prescribing, but it is bigger than that. So de-prescribing, what is it? It's hard to say, for one. And I think it's harder sometimes for our patients and community members to wrap their minds around it. But it's the structured, supervised process of withdrawal, dose reduction, or substitution of an inappropriate medicine with the goal of improving health outcomes and quality of life. So what is a potentially inappropriate medication, often referred to as a PIM? I think we hear a lot about them and that are high risk or dangerous. But I think a key thing for de-prescribing is that we also want to think about medicines where there's very low to non-existent benefit, that it's unnecessary, meaning it's not actually helping achieve an outcome that matters to the person, or that is should be driving the decision, or that it's not aligned with the patient or the caregiver goals. And so all of those are potential reasons where you might consider de-prescribing. So why is it so hard to de-prescribe? And I will be totally transparent that when I'm in clinic, I often have learners with me. They know that I study de-prescribing. It is not uncommon that I'm like, yep, this person's on 8 or even 11 medicines, or that I know that this may be a medicine you've been taught to use with caution in older adults. Like it is really challenging for us to be doing this well. So why is it so hard to de-prescribe? Well, we often are semi-protocolized, right? That there's guidelines. There may even be quality metrics or BPAs that are driving you to do things. Prescribing medicines often feels like it's directly addressing a problem and it feels helpful. And it's often much easier to obtain than non-pharmacologic treatments. When we think about something like a cognitive behavioral therapy, right? Like that can be challenging in certain geographies, certain insurance, certain amount of resources, just in terms of certain availability, right? To be able to get people to be able to access that. And so it can, I think, sometimes be easier to start a medicine. For stopping, we have few guidelines that tell us when or how to stop. There's a fair amount of inattention and inertia, not just when we're seeing the patient in front of us, but when I get a refill request in between visits and they want me to refill it for a year, right? Like the patient's not in front of me. It's a hard moment to be like, oh, maybe I should rethink this, right? It's definitely easier to just refill something. Multiple clinicians, clinicians are often afraid to change a medicine someone else started, particularly if they don't have a relationship or an easy way to get a hold of that other clinician. It can feel like you're taking something away. And I think that there is a anxiety around like, what if I stop this and the person has a stroke or falls, so on and so forth. Excuse me. So the process of stopping a med is not just the reverse of starting it. I think the big concept when we're thinking about this patient population is that we want to move away from a system where we're putting like an individual disease at a time in the center and maybe thinking about other things around it, right? But that we're doing that sort of disease by disease, osteoporosis, COPD, hypertension, right? And really be trying to think about all the conditions that someone has, recognizing that they overlap and intersect to varying degrees, and that whatever those are, they exist within the context of a patient. But they also may not always be what we think of as a disease, right? Like we need to be thinking about falls as a condition that is overlapping with someone's osteoporosis, their heart failure, their hypertension, and so on. So I wanted to share work from the group that is called Patient Priorities Care. I really like their tagline, choosing what matters, doing what works. The goal of this is that patients' health priorities drive all care and communications, and we really need to start with that. If we get everyone, patient, caregiver, and all clinicians to focus on the same outcomes, we can help people achieve the things that matter to them. Roles and responsibilities need to be agreed to among the team, but that when we make decisions, we are going to have to acknowledge that there's uncertainty, that people's health trajectories vary, and that there are trade-offs, and that we have to be able to integrate across conditions. So this is a schematic that this group also developed, which I think captures a lot of the patients. So when we're struggling to decide whether or not disease-specific evidence-based guidelines really should be a driver or pushing us to do something or not, thinking about which bucket patients are in can be helpful. So when people have a very advanced or end-stage illness, right, we may be moving towards de-escalating treatments, palliative care, and symptom management. There may be people with multiple chronic conditions for whom the guidelines are appropriate and consistent with their preferences. But there's probably a large bucket of people in the middle that have increasing number and severity of conditions that are having impaired function, where a thoughtful process of really understanding what outcomes matter and trying to keep that at the center so that you're using that to help guide which things are actually most beneficial for the person in front of you. This schematic shows that these concepts that I've just been talking about are something iterative, right? Like when we first meet someone, it's often a good time to identify their healthcare priorities and understand how they're doing and what their health trajectory is likely to be. But it may be that we need to revisit that, right? Like the first time we meet someone, we may be focused on a very specific issue. A next step in the process is that we have to decide what we're going to do. And a key piece of this is that we should think about continuing treatment for something as an active decision, much like stopping and starting would be. It's much easier to treat it as something that just kind of keeps rolling along. And that we need to make sure that when we're doing things that we're aligning them with the patient and caregivers and other clinicians. So the American Geriatric Society was actually one of the first groups to take on this challenge of how do we try to give guidance to people for the care of older adults with multimorbidity. And I'm going to tell you a little bit about the principles. I will share that there have been both nationally and internationally further efforts in this area, and many of them build on this approach. There's a guideline from NICE. There was a international systematic review about this a couple of years ago. So I do think these principles are gaining traction. I think the first piece that you to think about is what kind of visit are you about to enter into? And basically this schematic shows each step of the process, but we're going to go through each one. But first we need to understand what is the patient's primary concern and any additional objectives. And obviously sometimes family will have something to weigh in. I think the next sort of decision tree is, are we thinking about the whole plan for the person, or are we focused on a specific care, right? That we're worried that the person is hypertensive or having low blood sugars or has fallen a bunch recently. But I think that this frame and thinking can help whether you're doing the overall approach or for a specific conditions. The first step is to understand what is the person currently doing and how good do they feel about what they're doing? How often are they able to do everything that is on their current treatment plan? So the next piece is, I'm going to walk you through the next steps, by telling you a little bit about a patient's story. So an 87-year-old man comes in complaining of fatigue and taking too many medications. He's accompanied by a son and a daughter who are his healthcare agents, and their concern is his safety and ability to live alone. They acknowledge that he has a high financial burden of medications, even on Part D. So here's his current care plan, and I think a couple things are helpful about thinking about it this way. Is that we're grouping it by the conditions the person has and what it's treating, which I do think is an important step to trying to make sure that we wrap our heads around the plan, because many times we'll find people who are on medications where it's not really clear what it is that we're treating or what's the indication. I don't know how medications come for you, but for us, they are listed most often alphabetically, right? Which isn't the way we clinically think about medications. And so I think recognizing that we're trying to sort of overcome those like organizational barriers in many health systems is an important one. So with his current care plan, you can see that he has a MMSE of 23, which is a little bit down. He has fairly low blood pressure and a heart rate in the 50s. He has a hemoglobin A1C that's less than 7, which appears to be on the downward trend. You can see his lipids from the past. He has an EF of about 30. He has a creatinine of 1.7. And one of the things that my nephrologist colleagues have taught me, right, is that oftentimes we don't even think about putting CKD on the problem list, but I think many times it is tracking right along with all the problems that you saw on the prior slide. And he's checking blood sugar, and he's trying to walk, although slowly most of the time, but does want to be able to get as much exercise as he can. So here are the 5 principles that we'll go through. So first, patient preferences. So this principle is to elicit and incorporate patient preferences into medical decision-making for older adults with multimorbidity. And I have the asterisk there because I didn't want to put too many words on the slide, but many times it is important to be understanding what family and friends are advocating, are concerned about, or are thinking about for their loved one. So for this patient, the patient and his children express the following priorities: to stay alive, to optimize quality of life, to reduce out-of-pocket expenses, and to remain safely in his home. And I think this is not atypical when you have conversations with patients, that the way they bucket things can be quite big or comprehensive. So then with that frame in mind, we want to think about the evidence. So recognizing that the evidence base is often limited for this population, we need to think about it and apply the existing evidence specifically to older adults with multiple chronic conditions. So I hope I said it clear enough at the beginning, but there's definitely not like one answer that I think is going to be right for these patients. And so I've just picked out a couple things with his plan in the interest of time, but just as examples of the kinds of way you might think about evidence for him. tight glycemic control may actually result in more harm than benefit for a patient like him. And that there is a fairly long time till you get to secondary endpoints until you see that benefit, which we'll come back to in a little bit. Donezepil has had modest and inconsistent effects on delaying institutionalization and functional decline. Osteoporosis is effective with a moderate absolute risk reduction. So the third principle is around prognosis. So we want to frame clinical management decisions within the context of risks, burdens, benefits, and prognosis. And keeping in mind that this is not just life expectancy, but it may also include prognosis for functional status or quality of life for older adults with multiple chronic conditions. So this is a schematic that comes from a paper about prognosis. There's actually a website called eprognosis.org that includes multiple tools that can help with prognosis. But I think one of the things that you can see here is that based on this patient's story, kind of where he would fall in terms of the risk for mortality based on the number of points that he has and what the survival rate is at each year. So, so using information like this, I think, is important as we try to weigh what things are most important for a patient. The fourth principle is around treatment complexity and feasibility. So we want to consider these when we're making decisions. And this is, I think, a place, right, where what we want sort of meets the capacity that the person has and also their desire for complexity, right? Some patients are made miserable by taking 4 pills a day, whereas other people won't hit that threshold until they're at 9 or 10. And so again, this is a place where I think we have to be prepared to individualize. So thinking about this patient's treatment plan, I've taken it and put it on a schedule of what it would look like for, what it would look like for a patient. And I think this is really important because for me, it reminds me to think about all the non-pharmacologic things that we do, as well as the healthcare utilization people are required to get. Just that I think it is an important step. I obviously don't create this for every one of my patients, but I think this concept of trying to talk to our patients is helpful. Our home healthcare nurses, when they see the agency we work with the most, they actually do create a schedule that's not unlike this for patients. And I think it can identify when some specific things are hard or challenging. Oops, oh dear, I went too fast. So here you can see some things that we learn from talking to the patient. He often is forgetting his evening medications because he's tired. He doesn't check his blood sugar regularly because the finger stick hurts, but it's kind of out there as something his family thinks he should be doing, and that he struggles with cost. And so have highlighted where we might think about this for this patient. So then we want to utilize strategies for choosing therapies that optimize benefit, minimize harm, and enhance quality of life for this patient population. And so in this case, in this principle is where we want to think about all the potential interactions among the diseases and the treatments. And so again, this is probably not not necessarily the exact list that someone else might come up with. They may have identified even others. Recognizing that he has so many conditions. But you can see that there's a pretty complex set of potential interactions between the treatments and conditions that are relevant for this patient. So how might we start to optimize a care plan? So I think a key thing is that very rarely can you do everything at once for a patient like this. Most often, I'm trying to do 1 or 2 things per visit, working towards something. over time, but occasionally you might be trying to do something more comprehensive closer together. But I think much like the mantra of start low, go slow, I think that if you take away a whole bunch of things or change a whole bunch of things at once, it can also be hard to know, well, what's made things better or worse. So another sort of plug for thinking about not more than one or two things at a time. But so how might we do this for him? Well, thinking about the diabetes, we have to weigh his preferences with the benefits and harms of glycemic control. We need to think about his prognosis and the outcomes that are relevant, and recognize that for him, tight glycemic control might actually be more of a problem than the prevention of secondary complications, 5 to 10 years down the road. So deprescribing is one way that we can improve meaningful outcomes in older adults. This is definitely an emerging literature. There's a lot of ongoing research related to this because it's both quite hard to do in practice and to figure out the streamlined ways to do this. But there are some signals to suggest that deprescribing for patients in nursing homes can help benefit mortality as well as falls, a little bit more equivocal for hospitalization. And in ambulatory care, comprehensive medication review also may have a benefit for mortality and conflicting data for falls and hospitalizations. So still much to learn, I think. When we're discussing deprescribing with people and families, I think that we have two sort of things we're trying to do. One is to be focused on when is it suitable to think about deprescribing. So we've talked about a couple of these principles already. Just want to kind of echo them. What are their treatment goals? What do they value the most? What has been their experience over the past 6 months? I think we all have seen patients who have a very strong opinion about a medication that they believe is giving them a side effect or a symptom that's not well treated. And what are their concerns about medicines? These are all opportunities, I think, to open that door to deprescribing. But then we also need to educate the patient to make an informed decision. And I think a key piece is that if we're going to deprescribe is we need to tell patients and actually follow through that we will monitor them and evaluate if medicines need to be restarted. Just as an example, I have had a patient recently who, for reasons I'm not quite sure of, got profoundly hypotensive. So I backed off her blood pressure medicine, but I told her what to call me back about, if her blood pressure crept back up. I still don't know why she had several weeks in the 90s and low 100s. But she got back up and we ended up restarting her medicine at a lower dose, and we're still monitoring. I think it's also important to note that there are both benefits and harms of continuing medicines as well as potential benefits and harms of discontinuing them. And so explaining why you think that it may be better to come off or be in a lower dose is important. There is unfortunately still uncertainty for many of these medicines in many of our patient populations. Our 85-year-olds with 5 chronic conditions are still not the average patient in heart failure trials, even though they are the average patient with heart failure, right? So we still have some uncertainty that we have to kind of wrestle through. I think understanding what patients or families are worried about if you stop is also relevant. And obviously, sometimes patients are unfortunately making decisions in part based on the out-of-pocket costs they can bear. This is an algorithm from the American Academy of Family Physicians that I really like, which is just, I think, a great schematic that shows kind of a way to think through. First, start off knowing what medicine someone's on, and then think through these buckets. And if the answer to any of them is yes, you would come down this path where for one or more of the medicines, you would discuss potential for deprescribing and gain agreement. And then obviously thinking about when do medicines need to be tapered or not. Some medicines do need to be tapered. So for the gentleman whose story I presented, here's one way to think about potential revisions to the treatment plan. Could we potentially reduce his metoprolol given the bradycardia and the relatively low blood pressures and the feeling fatigued? Could we reduce the zolpidem, which is definitely increasing his risk of falls? And is there really an indication for aspirin? Here are some medicine. So these might be things that over time, not that you would do them all at once, that you could consider cutting back on. Here are things that you could consider whether or not to stop. And then are there opportunities to simplify or modify the treatment regimen so that it's easier for the patient to be taking the things that you've agreed upon as most important? So when we're doing this, there's actually a pretty good literature that the way we communicate and discuss decisions actually matters. So when we're discussing options for diabetes, for example, we might restate his desire to remain at home and avoid hospitalization. Hypoglycemia is probably one of his biggest risks of hospitalization. And explain that, the years of really tight glycemic control may need to be adjusted for this time in his life where he's less worried about outcomes that are 5 or 10 years down the road. And my experience is that when I explain that, doing this aggressively is trying to prevent something happening for 5 to 10 years, I think most patients with this age and this degree of comorbidity are able to have a conversation around oh yeah, I'm really worried about how I feel now, not 10 years from now. That he's at risk for suffering consequences from low blood sugar, and that it may contribute to him helping to feel more energetic. And so, therefore, we suggest you reduce some of your medications and relax your effort to achieve tight glycemic control. So the words matter because being patient-centered in the way we approach care is linked to higher patient satisfaction and quality of life. We know from national literature that patients want to deprescribe if we recommend it in most cases. Patients and caregivers are often not aware of the potential harms of medications, and the patients who are engaged in decisions tend to choose more conservative treatments and receive less unwanted care. So one of my colleagues, Ariel Green, did a really beautiful study which tested the ways that we might explain how to stop a statin or how to stop a sleeping pill. And so this survey was developed with input from stakeholders. And there were 2 different versions of the survey, in part, right, because thinking about a preventive medication feels different than a zolpidem that is treating a symptom but may have a harmful effect. So here you can see older adults' preferences for how to explain deprescribing zolpidem. And what this data suggests is that overwhelmingly, most patients thought that the most important way to explain this was around increased risk of side effects. With the next most important thing to be talking about is that you're going to work together to reduce dose so that the patient is really going to be part of the partnership. And explaining the concept of the balance for benefit versus harms. You can see the things that were less popular, right? Can treat this without medicine, unlikely to help you function better, and so forth. But it does give us some clues for how we might be able to tell the story of why zolpidem should be reduced or eventually stopped. Oh, sorry. There's my animation. Sorry about that. So I just also share this page, which I think is a nice description for patients and families that to try to be setting the stage. One of the things that I tell my patients when I'm starting a new medicine is I want you to start taking this for whatever reasons. It's going to help you achieve, these things that you told me mattered to you. But you and I are going to reevaluate this over time and make sure it continues to be the right medicine. there are a fair number of patients that I wish had had someone say something like that to them when someone started their, their aspirin 40 years ago. Because people hear like you're going to take this for the rest of your life. And I feel like we need to be a little bit more nuanced than that. So I hopefully we have a couple of minutes for questions, just have some resources here that may help people, and I'm happy to take your questions. Yes, now I can.
Perfect. Just a slight delay. Thank you so much for that wonderful talk. We've got a whole bunch of questions in the chat. So I will start with the one that got upvoted by the most people, which is Dr. Boyd, wondering about tips for documenting so that other providers don't resume meds that you have stopped. I think we've all been there.
Oh, yeah, that's great. I actually would love to hear what other people are doing. Like I am definitely working on trying to make sure my notes contain the information and that it's easy to find. That it's not sort of buried in like 6 pages of documentation. So I think that is something that's really key. I try to bold or reduce the amount of what I'm saying to the things that are particularly important. I think this is much easier when you're in the same health system. I try to send a staff message, like a chat message, say like, hey, I saw so-and-so today, because of X, Y, or Z, I really feel like she needs less of this. So we reduced it to this. I told her to let me know. I see you're seeing her in 6 weeks, wanted you to be aware of the change. How often that like sticks, and that when the person is seeing the person 6 weeks later, that still stick in their mind. But I think when we have the ability to do that, it's really helpful. One of my colleagues here is studying like how do we actually get like kind of a comprehensive plan that could follow people easily from one place to the other. The patient priorities group that's really doing amazing work, I think, is also thinking about this a lot. Like, how do we actually align and get on the same page? And I think that they would say that really like making sure that you're partnering on that everyone understands what outcomes you're trying to achieve is a critical step to keeping everyone sort of aligned when medications are changed. But in terms of the details and practicalities of it, I think we've got the personal outreach. I think trying to make our documentation simple and clear. I think also, when possible, making sure the patient and family are able to understand or speak to it also, because they often are a mechanism of bringing the information.
That's a great point. Thank you so much for that.
No, I still work to do. So if anybody's written a great idea in the chat, I definitely want to hear it. So
keep your ideas coming in the chat, people. We have 2 questions that are kind of similar, so I'm going to combine them into one question, which is someone is asking, what's the best approach to stopping GLP-1 in elderly patients who want to continue it despite education on sarcopenia? And related to that, Dr. Boyd, what strategies do you recommend when patients or caregivers resist deprescribing, even when medications are no longer indicated? If you could speak to that.
Yeah. So I think I'll take the second one first. So I would say that this is one of those things that like you just kind of have to keep at it. I had a recent patient who had been on a sleeping medicine that I literally had tried to stop for years. And whenever I had learners with me, I would be like, I try to stop this every time. Like we've not been able to do it. But she basically ended up getting started on a new medicine by someone else and had a drug interaction with it, which then made her be very motivated that she actually wanted to taper and get off of it. And, so is there something I could have done sooner? I don't know. But like, I think the fact that I had been very consistent about saying that I continue to worry, that I wasn't going to increase it, and that like here are other things you could be doing. Like I think it kind of set the stage that when there was a change. In my mind, I think we do our patients a disservice if we just try once or twice and then don't ever try again. I know how time consuming it is. Certainly there were a lot of intervening visits where it was a lot shorter. And I said, I really worry about this medicine that you're taking, but I wouldn't spend 10 minutes on it. So I think the other thing I would just say is that for many drugs that we worry about, there's actually really good patient information created. I don't think I have it as a link, but it's pretty easy. But deprescribing.org, which is the Canadian Deprescribing Network, they actually have developed patient tip sheets for many conditions. But a lot of the literature suggests that as we try to educate patients and families, that actually may be even more important, or if not as important as what we say in a visit. And so they have good materials for like zolpidem and benzodiazepines and proton pump inhibitors. I'm not going to remember all of them. So it's deprescribing.org. And then, the GLP-1 one, I will admit that I've only had a few patients who are on it. And I have definitely had one where I advocated that we needed to cut back the dose. They're still taking it, but at a much reduced dose. And so that is definitely a place where I'm still learning and, trying to wrap my head around. I've only had a handful of patients who are on the GLP-1s.
Thank you so much for that. I think we have time for one more question, and I like this one. Let's hear it. If you had to pick one medication to deprescribe, what do you think the highest yield one would be? I assume they mean for society.
Ooh.
No pressure.
Oh gosh. For older adults, I'm assuming.
Yeah.
I think it depends what outcome. I'm sorry that I'm having a hard time with that question. Very good question.
It's a hard question.
I think it depends a little bit about like what outcome you're valuing. So if I put it as like hazards, drug interactions, bad things happen to you, whether it's falls or cognitives, I think I would definitely say the bucket of things that are CNS active, of which one of the biggest drivers is the sleeping pills, both over the counter and prescribed. But I think that you could come up, if you had a slightly different lens, I think you could end up choosing a different medication.
So many great options.
Yeah.
And thank you so much for your talk this morning. We really appreciate you coming to speak with our group this morning.
And I will do some research about the GLP-1. So thanks.
Okay.